Thank you, everyone who has already joined. We are going to get started in just another minute. Thank you for joining us for this installment of the Root Cause Coalition's How-To webinar series. My name is Rachel Carlson, and I'm the membership coordinator here at the Root Cause Coalition. Before we get started, I want to go over a few logistical items for the webinar. Attendees will be in listen-only mode for the duration of the webinar. The webinar is being recorded and will be available to view at rootcausecoalition.org later this week. At the end of the presentation, our panelists will be taking audience questions. If you have a question during the presentation, please type your question into the question pane located at the right side of your screen. We are so excited to have our esteemed panelists today from Alive and Well Communities and other organizations. And at this time, I would like to pass it off to Abe Stokes from Alive and Well Communities.
All right, thank you. I hope everyone is having a great day. My name is Abe Stokes. I'm the director of Alive and Well Kansas City, and in a moment you'll hear from some of our other leaders and directors with Alive and Well Communities. Alive and Well Communities actually started in Kansas City, St. Louis, Missouri, under the Regional Health Commission, and started as an awareness campaign, but really picked up a lot of traction throughout the community and different organizations, and became its own 501c3 and started out as Alive and Well St. Louis. From there, last year, probably around March of 2018, as of March of 2018, we have Alive and Well Kansas City, and together, St. Louis and Kansas City make up Alive and Well Communities, and we are also expanding into other areas around Missouri and some neighboring areas. So without further ado, I'll hand it off to Sean, but before I do that, I'd just like to quickly tell you kind of what we cover. So Alive and Well is really focused on creating trauma-informed systems, organizations, institutions, and communities, but also looking at ways to redefine how are we defining community. So, for example, am I organizational during the day, and then when I take my badge off at night, am I now community, or are they actually one and the same? And where does trauma connect throughout all of these different systems, organizations, and community? And how can we really work to bridge that gap between what we view as community and residents and neighborhoods and as our organizations and institutions? So I will now hand that off to Sean, and Sean, I'll let you take it from here.
Thanks so much, Abe. Rachel, can we go to the next slide, please? So Abe mentioned what we do as an organization, and we're very proud that we live by our mission. And in each one of the communities that we serve, we have a unique steering committee that determines how we enact this mission. But our mission is very much so community-centered, and with a focus on activating communities to heal. And we do this with a vision of elevating that community wisdom, recognizing that we have to listen to our community, and our community voice needs to be centered in everything that we do. That we can't truly build alive and well communities until we disrupt the systemic oppression that's causing historical trauma to persist today. We have to do so with urgency, recognizing that we can't wait another day. We can't allow trauma to persist and affect yet another generation. And making sure that we're using that community wisdom to generate innovative solutions using the science of trauma, toxic stress, and resiliency. So as alive and well communities, we activate communities to heal, recognizing that that potential is within the community, but that we have to help ensure that that systemic oppression is disrupted to allow that community wisdom to be elevated. Rachel, can we go to the next slide, please? So before I move on, I want to introduce a special guest I have with us today. I know that in the webinar description that we listed Bethany Johnson-Jovois, who is the Chief Executive Officer of the St. Louis Integrated Health Network. And Bethany, in addition to her outstanding work that she does to help protect the safety health net here in St. Louis and the state of Missouri, is also the board president of Alive and Well Communities. Unfortunately, due to illness, Bethany is unable to join us today, so we wish her a speedy recovery. And I have to say, I am very excited that we are being joined by Ms. Rosetta Keaton, and Ms. Keaton is not only a personal mentor of mine, but also a great mentor to Alive and Well Communities. At Alive and Well Communities, we were joked that Rosetta is actually our very first ambassador that we ever had. She's been central to the development of Alive and Well Communities. She, for many decades, has been a patient advocate, has really been implementing and a champion of trauma-informed work before there was even this language. And so I'm so very excited that Ms. Rosetta Keaton is here with us today to share stories, really highlighting how we see this in St. Louis. And so today, as we move through our webinar, we're going to illustrate some of these examples by using St. Louis as a case study. And no one could do that any better than Ms. Rosetta Keaton, who's definitely a champion of healthcare here in the St. Louis region. So we're very excited that she's joining us. Before we get kind of rolling into the core of today's presentation, we wanted to do just a brief review of understanding trauma. And if you joined us for the last webinar, this will look very familiar. That rather than using a very clinical definition to understand trauma, we use this framework from SAMHSA of the 3 E's. And first and foremost, inherent in the 3 E's is that trauma is an individualized experience. That what's traumatic for me may not be traumatic for you or for a neighbor, or that two individuals going through the same exact traumatic event may not identify as such. That first and foremost, trauma is individualized. And this framework helps us to understand that. So that first C that we're looking at is the traumatic event, and that's any threat to safety, whether it's physical or psychological safety, whether it's an actual threat, or whether it's anything I may perceive as a threat based on my lived experience. Recognizing that that perceived threat is just as real to the brain and body as any actual threat to safety. Now that's pretty intuitive, but the part we want to really focus on today is that second piece of the event. And that's the lack, withholding, or control of those resources needed for our health and healthy development. Recognizing we have relational and material needs for our healthy development from the day we're conceived till the day we pass. And recognizing the lack, withholding, or control of those resources is traumatic. And that's going to be crucial to our understanding as we move forward today. The next C is the lived experience, and this is going to be how an individual finds meaning to that traumatic event. So this is going to be shaped by, has the individual previously experienced trauma, or is it a one-time event? What are those internal capacities an individual comes to the table with? Things like personal resilience, ability to cope around self-worth and self-concept. And then based on that lived experience, we're going to see very different effects. What we want to recognize is how we have to remove our bias from the traumatic event and recognizing it's less about the event and more so about the lived experience and the individual effects for the person. Can we look at the next slide, please, Rachel? So as we discussed last time, the Adverse Childhood Experiences Study, which was conducted back in 1995. And this was really a powerful and seminal piece of research that helped us understand the true power of trauma. That trauma isn't just the psychological experience, but that childhood trauma, if it goes unintervened upon, can literally take years off someone's life. And recognizing that true power of trauma helps us to understand where we intervene and how we build a life and wealth. But what we also have to recognize is one of the limitations of the ACE study conducted back in 1995 is that it really focused on just this limited list of 10 adversities. And in addition to that, we're looking at interpersonal adversities here. As time has passed and our understanding of the signs of trauma has evolved, we know that it's not just the interpersonal experiences of trauma that are impactful and that have those lifelong impacts. Can we look at the next slide, please, Rachel? So this comes to us from our national partner, BCR, Building Community Resilience, this concept of the pair of ACEs. And so if you look at around the leaves of the trees, you see those adverse childhood experiences. But what we have to understand is not just those adverse childhood experiences, but what are those adverse community environments? What's below the soil in which our trees are growing? What's in the soil that's either helping or preventing our communities from thriving and living a life and well? And understanding these adverse community environments truly as toxins in the soil, inhibiting our communities from thriving. From a national perspective, BCR has identified as poverty, discrimination, community disruption, lack of opportunity, economic mobility, and social capital, poor housing quality and affordability, and community violence as those toxins. Recognizing that in each community, those toxins may vary, and those toxins may be even more specific. As we think about St. Louis and St. Louis's very racialized history, we know that we're not just looking at discrimination, but we have to be able to name racism. Because until we're able to identify and adequately name the toxins in our soil, we can't even begin to address them. What we also want to recognize is the power of those toxins in the soil. These toxins aren't typically just a one-time experience, but rather they're an ongoing, persistent experience. Recognizing that these are toxins that our community is experiencing day in and day out, 24/7, without a break. So recognizing that these toxins in the soil perpetuate those adverse childhood experiences. We have to recognize the power of these toxins, and we have to be able to name them to address them. And we also have to recognize that this isn't a one-time event. We know that too long in the trauma movement, we just discussed interpersonal trauma. And we now know that we have to discuss those adverse community environments if we're going to build a life and well-being. Rosetta, is there anything you wanted to add to this slide?
There's nothing that I can add except to agree with you completely about the adverse community environments being the catalyst to the adverse community experiences. In St. Louis, we have history adverse community environments that have perpetuated, and I'll use healthcare as one of our primary categories that we have always seen the adverse community environment be affected by. In St. Louis, we have a history of healthcare discrimination, and it has always been prevalent since my mother, and if I say I've been an advocate for 30 years, that means I didn't just become an adult. So over 40 years or 50 years, we know that we have experienced healthcare racism and discrimination in St. Louis, starting back to when we had a white hospital and a black hospital. And because there was such racism and discrimination in St. Louis, when there became an opportunity, or not an opportunity, but a time when there was a financial need in the city to close one of those public hospitals, even though the black hospital had been the hospital that had all of the recent improvements and the most latest equipment, that hospital was closed. And that hospital served the black community, where over 50 or 60% of the people living in that community got their health care because they couldn't go to the white institution, which is why the black hospital was built. But they closed that hospital, causing those people so much trauma. You look at every adverse community environment category listed, and closing of that hospital helped perpetuate all of those things. Poverty, the community became extremely poor because the hospital no longer supplied the jobs. The discrimination was always there. They couldn't go anyplace else. And when they were sent to the white hospital, they only had white doctors who knew nothing about taking care of black people, understanding that white people, our example was, talk to God. They used to have psychological consults for black people who said they asked God about whether they should have a surgery or not. That really happened in a lot of the records that we found. And of course, the community was terribly disrupted. All kinds of things were happening there as a result of the hospital closing, lack of opportunity, economic mobility, social capital. Of course, the housing became poorer. People couldn't afford to keep the housing up. They couldn't buy new housing. And as a result of whenever people are traumatized, you don't know what the effect is going to be and how that self-esteem is going to be experienced and expressed. And so there was violence. As we see today, that community still has not thrived. As a result of that history and those health conditions, we still have communities that have not thrived, and they have violence as one of the key components that we see in a lot of those same zip codes. And I think that is a prime example of how adverse community and history of racism can affect a community, the community environment, and as we see, as the roots move and the limbs begin to grow out, we see those adverse childhood experiences that are still going on today.
You know, Rosetta, I think you highlighted a lot of really great points there, recognizing that not all the toxins here are named, that we have to think about access to care, and that we have to think about all the multiple toxins that may be in our community soil. And additionally, also recognizing how it's typically not just one toxin we see someone experiencing, but really that intersection of toxins. So thinking about the stressor someone's experiencing each and every single day, constantly, nonstop.
And how that affects the next generation that's coming along. I can't help but speak to the violence that we see in the communities these days, and especially when we see in St. Louis the youth in those zip codes that have experienced all of these adverse and are still experiencing all of these adverse experiences and effects, and how violence has been perpetuated generationally. Because I'm not a psychologist and I'm not speaking psychologically, I'm speaking what I see. We see youth not feeling good about themselves, youth being taught experiences that they see, they taught things to see from experiences that are not necessarily those things that are good for them, and needing to feel good, doing things that the world sees as a negative, and that are actually probably some things that are there, where we never stop to say, why are these things happening? What happened to cause these young people to be taking the world as they see it and acting the way that they act, being violent, not seeming to have feelings? That trauma that these young people have experienced is so toxic, and the stresses and the trauma that go on in their lives have been generational. They got generational trauma that moves up to the next generation. I can see 4 generations of trauma that have existed with these people. I'm going to shut up because I get on the soapbox.
So I think that leads us perfectly into the next slide. Rachel, can you take us to the next slide, please? So when we think about the layers of trauma, we have to understand the complexity of one's lived experience. We know that too often when it comes to addressing trauma, we only look and see that interpersonal trauma. But what we have to recognize is individuals are complex. Individuals have multiple layers. And recognizing that underneath the interpersonal trauma one may have experienced is that persistent day in, day out trauma, those adverse community environments that one experiences. But one of the things we hear too often is that there isn't an understanding of how current community trauma evolved. And what we have to recognize is that the community trauma that we see today is really rooted in that historical trauma. And as we think of that systemic oppression of certain populations historically, or whether we think of transgenerational poverty, recognizing that historical nature and how that community trauma is rooted in that. But what we also want to recognize is how at the core of one's lived experience is that systemic oppression. And we know that based on one's identity or multiple identities, that an individual can be exposed to increased vulnerabilities of trauma, of increased amounts of trauma. And recognizing that if we're going to address trauma, if we're going to truly build a alive and well community, it's not just about addressing the interpersonal trauma. It's about addressing the community trauma, the historical trauma, and the systemic oppression. Now, what we've also done, you see those dots on the sides of the onion slide. And what we want to acknowledge is that there are multiple toxins in the soil. And recognizing that through my own lens, through my own frame of reference, I may only be able to name certain toxins. But that doesn't mean that for other communities, there are other very real toxins in our soil. And making sure we save space to recognize that there are multiple toxins, and some toxins impacting only specific populations. But without that recognition that there are increased toxins that we may not be able to name, we then allow trauma to persist in silence. And, you know, Rosetta, your example of the closing of Homer G. Phillips Hospital, as we think about purposeful investment versus purposeful disinvestment in communities, then access to resources, and then how we see varying zip codes in our St. Louis community with poor health outcomes, and not being able to equate those poor health outcomes today as it connects to that historical trauma of the past. I was wondering, are there other examples that come to mind as you think of how systemic oppression is at the core of one's experience of trauma as we think about specifically here in St. Louis?
So I think about, I'm going to go back to where I use this often, this story often, because it's kind of personal to me, and it's historical. It goes back to my father. My father telling us when we were kids about the soot. Soot was just black dirt that came out of the factory's chimneys in our poor neighborhood. And so the smoke and the toxics that came out of the chimneys just filled the community in the air and filtered down, and we would have dirt on us from just the factories. And there were no regulations, and nobody really concerned with systemic oppression. Nobody really concerned about the poor folks that lived in the community that got all of the soot and as we call it, the soot. But it was the dirt and the chemicals that came from these chimneys of these factories. And my father said to me as I got older, and it seemed that there was no more smoke, and there was no more dirt and soot on our bodies. He said to me one day, just in an observation, he said, you know, when dirt and the black clouds were just in our community, it was called dirt, and those people didn't wash their bodies and didn't take care of themselves. He said, but it's a strange thing when it moved out to the county, well, that's where the more affluent people lived then. When the factories started moving out there, and they had the soot and the dirt coming out, somehow or other, there were some regulations done, and it got a little better. And he said, isn't it amazing now they call the same thing pollution? That to me was just a good example of how when it started to affect, how when the pollutants started to affect people in the more affluent community, it became a need to be concerned about the health of that community. Whereas when it was in the poor communities where I lived, so people still had lung disease. As a matter of fact, my father died from a lung disease. And people were still getting sick with emphysema and everything. But nobody thought that it was because of the systems, the pollution in the air. It was just called soot and dirt that happened where these poor people live. That goes all the way back to systemic oppression, and it goes up through historical trauma on up to community trauma until somebody decided a better way of handling it. When people who were not black, brown, or yellow were being affected by it. And in St. Louis, I know that wasn't that because I lived it.
Thank you, Rosetta. Thank you for sharing that. Rachel, can we look at the next slide? You know, just as we heard in Rosetta's story, that too often our natural inclination is to ask, what's wrong with you? You know, what's wrong with you that you're unclean?
Yeah.
Versus asking what happened. But we know that in order to build alive and well communities, we have to change the question from what's wrong to what happened to you, and also ask what's continuing to happen. But we need to not just ask this on an individual basis. We need to ask this on that kind of macro level. making sure that we ask what happened and what's continuing to happen as we see disparities continue to persist. As we think about different points of access that we have in today's world, recognizing why is it that those disparities in such great magnitude still persist in today's world, asking what happened and what's continuing to happen, starting to recognize what is truly the root cause that's preventing our communities from living alive and well. And until we start to ask that what happened to you question, not just at the individual level, but also at the systems level, we can't truly begin to address trauma. We can't truly begin to live a life. And we know that when we ask what's continuing to happen, it means we have to name those toxins in the soil. We have to name those adverse community environments. Rachel, can we look at the next slide, please? So we do this by infusing the core principles of trauma-informed care. And those core principles of trauma-informed care are safety, trustworthiness, choice, collaboration, and empowerment. Recognizing that as we think about these core principles of trauma-informed care, it's not just for those we serve, but that in a trauma-informed community, in a trauma-informed system, school, healthcare organization, it's equally about those who do the service to promote this well-being of our entire community. But what we have to focus on is that word in summer, equity. We have to recognize that these principles must be equity-centered, that equity has to be the glue holding these principles together, and that only as these pieces come together in a puzzle can we work and start to achieve equity. But we have to also realize that as long as inequity persists, we can't truly build trauma-informed communities. We can't truly have a trauma-informed healthcare organization or system. That we have to actively address the inequity in order to be trauma-informed. So with this notion of needing to recognize equity and recognizing those adverse community environments, we want to take a few minutes now to look at the social determinants of health. Rachel, can we look at the next slide, please? So here we have this beautiful slide from the Kaiser Foundation, recognizing the various social determinants of health. Now, too often when I hear individuals talking about the social determinants of health, and we've gotten much more comfortable using this language in healthcare, but too often when we talk about these, I still hear that what's wrong with you question being posed. And instead, we have to work to change it to what happened. But when we hear about employment and hearing someone unemployed, that they have this need for transportation, that they may not have that education, and that's why they don't have that access to the employment. Too often we just focus on the individual and asking that what's wrong with you, versus asking what happened, as well as what's continuing to happen. And we understand how those social determinants of health have an impact on health outcomes. But until we start to shift that notion of what's wrong to what happened, we can't start building trauma-informed communities, and we can't start to shift outcomes for individuals as well as for our communities, especially when we take that blaming approach. Rosetta, I know there's a lot that you deal with on a day-to-day basis when it comes to social determinants of health. And so I was wondering, is there anything that you want to name or highlight or talk about?
I could probably talk about something in every aspect, social determinants of health. I'm looking at the table that you have here, and I guess death and medical bill is pretty strong. really strong and something that I really like to talk about. Debt is, people acquire debt for many, many reasons. And one of the common statements that I hear all the time about people acquiring debt is that they're irresponsible, and people look at certain communities as being irresponsible because they have debt. People have debt because they don't have money most of the time. Now there is that exception. They tell me in everything 5% of everything is outside of the law. So yes, there are people who have debt just because they can spend. But my experience is that people generally have debt because they don't have money or access to means to get things, and that those people who are empowered to give the money or the resources or whatever take advantage of people who have debt. It appears that the poorer you are, the higher your interest is. And that particular population of people is usually preyed upon. We hear about all of the money cashing shops or whatever they're called, who charge these people so much interest on their checks when they get them. They get their checks. $100 check, you may get $50 out of because you had to pay so much interest to get it. And I mean, they're exaggerating, but just a little bit to get it cash. And God, don't borrow money because your family needs some food, or your rent needed to be paid, or your electric is going to be cut off, or your gas is going to get cut off. And this is the only way you can get the money. Those people get taken advantage of, and so they stay in debt. They don't have any way of getting out of debt. And medical expenses and medical bills added to that debt creates such a hardship on people, and that is so traumatic for families to have to deal with medical bills and debt that it's almost impossible for them to not be in some type of traumatic lifestyle on an everyday basis. They live with trauma as a result of that. And I think the economic stability, I just chose those two because I could take that and go down each other column and name something that would affect whatever as a result of debt and or medical expenses and medical bills. So I'll just stop right there with that one.
And you know what's so interesting about each of these columns that we're looking at is that you'll see that they look familiar. Mm-hmm. And these, what we have to recognize, are the toxins in our soil. That these are the toxins that inhibit our communities from growing alive as well. And that as a result of these toxins in our soil, we see that individuals are then, once again, more vulnerable to that interpersonal trauma. You know, one of the things we often talk about is food. We often talk about how in various zip codes we see these food deserts. Now, food desert is no longer a term I use because we think about a desert being a naturally occurring, right? But recognizing how these food, quote unquote, deserts are actually the result of purposeful disinvestment in communities. So it's not a naturally occurring phenomenon, but it's really the food apartheid that many of our citizens have to endure. So recognizing that these toxins in our soil, these are daily stressors that individuals experience, and recognizing what is the impact on our health, our well-being, our ability to thrive when we're faced with these day in and day out. Rachel, can we look at the next slide? So, you know, we talk about social determinants of health, and there's a lot of controversy around that word determinant, recognizing that these don't have to be deterministic, that these determinants really increase someone's probability. But what we want to push at Alive and Well is recognizing that until we disrupt the systems and the context that allow these toxins to persist, that we know that the most vulnerable in our community are the ones that endure the most amount of trauma as a result. So if we want to start to move away from social determinants, we have to begin as healthcare organizations to reimagine the system and be disruptive, recognizing our healthcare system has the opportunity to be a place of healing, to be a place of resilience, but it can't do so until we work to disrupt the system in which these toxins are allowed to persist. So one way to do this, in thinking about a very trauma-informed approach, is moving away from kind of these universal approaches to targeted universalism. Now, universal approaches, they really perpetuate this idea of not equity, but equality, meaning everyone gets the same. But what we have to understand is that in an effort to provide everyone with the same, is that too often what we see historically is that minority populations are further marginalized, that we see inequities actually magnified when we implement universal approaches that aren't targeted to populations. So what we have to understand is, how is it that we work in a trauma-informed way to truly disrupt the system that impact the health and well-being of our community? So as we look a little bit more closely at targeted universalism, Rachel, can we look at the next slide? Let's talk about how this is done. So targeted universalism really takes an equity approach. So in targeted universalism, we identify the problem, but as we think about identifying the problem, and as we work to propose solutions, we bring community to the table. That community helps us to identify the true scope of the problem and to help us come up with realistic and adequate solutions to address the need. Now, here you'll see in red, it says particularly one suffered by marginalized people. What we want to understand is that as we first look at proposing a solution, we want to look at those individuals who are most impacted by that inequity, who are most marginalized by that toxin in the soil. And then as we work to propose a solution, we know that we don't just want to then broaden its scope for just that population, but we ultimately want to broaden it to cover as many people as possible. We know when we first pay attention to those most impacted by that socio-ecological context, that we then ensure that equity piece is addressed, to then make sure that others have access and others receive then those services, those goods, and the change in that environment so we can all grow alive and well. So what I want to do is I want to share with you all something that we've done here in Missouri, and something that I'm very proud to say that our board chair, Ms. Bethany Johnson-Gerwa, who couldn't join us today, was very instrumental in seeing through as we apply this kind of trauma-informed lens that has that equity approach. We know that, especially in St. Louis, we know infant mortality is unfortunately a big issue. And it's one that's actually near and dear to my heart, and actually hurts to think about that in this day it's appreciated. But as we disaggregate the data for infant mortality, we know that Black women are 2 to sometimes 3 times the rate impacted compared to white women in our community here in the greater St. Louis area. Now, it was so interesting when we further disaggregated the data, we looked at educational attainment, because, you know, one of the great American myths is that education solves it all.
Yeah.
That through education, anything and everything is possible without recognizing the interplay of those other toxins. And so what we saw at each and every single level of educational attainment was that there was still a disparity, even for women who had a college degree or higher. We saw great disparity of statistical significance between Black women and white women. So addressing infant mortality here in our community and working with community to identify, as we look at infant mortality, what is it we need to address if we're going to start narrowing this gap? And so working with community members, recognizing that Black women in our community are faced disproportionately with this issue, Black women were asked, how do we address this? And one of the things we learned is that access to transportation is a huge issue in our community. And so working to not just provide access through Medicaid providers and through HMO providers, but really designing a transportation system that met the needs of the community versus a program that was designed and then given to the community and said, here you go. Now, what's so interesting is that as we started to roll out this transportation program here in the St. Louis area, what we noticed was people were showing up to appointments, fewer missed appointments. We even saw higher utilization of emergency room services as well as NICU services when there were issues because of access to transportation, and transportation that was designed with a person-centered focus. But in doing this, what we did was we then changed procedures and protocols around the state for all pregnant women. And we're starting to see that rates of appointments for all pregnant women, we're seeing that no-show rate start to decline as well. Now, as we continue to broaden the scope and recognizing that it's not just about targeting a single community, recognizing that transportation is an issue for many members of our community, that we see that these procedures were not then just implemented for pregnant women, but also for individuals needing any sort of transportation while being under a managed care program, and how we're starting to see higher utilization of medical services in our region. And we're really looking forward to the data as this program continues to broaden and understand what it means for our region. But what we have to understand is that if we don't understand the needs of our communities and understand the differing needs of our communities, when we only use a universal approach, those specific needs aren't met. So when we target first the population that is most impacted, most vulnerable, most traumatized by the experience, and then broaden its scope, we can really start to address equity to ensure that outcomes truly shift in our community. So thinking about how is it, as we think about building alive and well communities, that we really take this community-centered, this person-centered approach to addressing those toxins in our soil, to not just reactively addressing that interpersonal trauma, but how do we proactively address those toxins to ensure that future generations don't have to experience and live with those toxins. Now, I know that Rosetta and I have been very verbose today and in such short time, and I know we're right at about that time. I wanted to quickly see, Rosetta, did you have any final comments as we move to questions?
I don't. I just appreciate that we are speaking in regards to equity, of looking at specific communities first that are most affected and most traumatized, and then going outwards instead of deciding that it's a universal effect that will solve everything. I'm appreciating that thought.
So with that, Rachel, I think we're ready to answer any questions. And I'm also going to invite Abe to join us back for these conversations, especially since Abe has such a rich history and lived experience of working in the healthcare sector.
Yes, and the only thing I'd add is that, and I know we'll cover this more in a later podcast, but just really taking into consideration the history and how we got here. So even when we talk about communities in the current state and these pockets of poverty that we have from historical redlining, and then even looking at our education system with education being an indicator of suspension rates and graduation rates, and then even going beyond that to look at how youth and young adults and individuals in general engage with the criminal justice system. So just looking at the trickle effect of, the housing policies within the 60s and 70s that excluded populations and groups of people, and how we're now seeing the effects of that today. And I say that because I was actually having a conversation with someone earlier, and, his response in the conversation was, hey, but that was 50 years ago. And so, I think it's always important to acknowledge the history, and that we didn't just wake up here overnight, and we're not talking about social determinants of health as anything that's particularly new, but it's something that's always been in our communities.
Wonderful.
Yeah, so
Rachel,
yeah, so we're going to open the floor up to questions now. I will wait just a minute to let anybody get any last-minute questions, and then we'll read out some questions to our presenters. So the first question we have, and anybody can continue to submit questions throughout this question and answer session. We'll try to get to as many of them as we can. The first question one of our participants is asking about is that they are also from a community that has had a lot of adverse community events that have happened in the last 100 years, similar to what Rosetta's been saying about St. Louis with the hospital closing and such. And this person is wondering if there is such thing as a adverse community environment assessment that communities could put together to inform local discussions.
Rachel, can you say that piece again? If there's an adverse community environment, I couldn't catch that piece, I'm sorry.
Yeah, an adverse community environment assessment. So I think sort of bringing together people who have this historical knowledge to understand and how to work with them to make the future better.
So there's not a formal assessment, but what I would encourage, if you have that much community wisdom, is to start with a blank tree and just begin naming the toxins in the soil. We also want to recognize that the toxins we listed aren't specific to one community, but it's a broad sweeping overview of the nation. And so as we look at the community in St. Louis, it's going to look a little bit different. But one of the things we also want to recognize is that not all toxins may equally impact or may impact certain populations whatsoever. So I think it's important when you do kind of a community assessment of identifying what are the toxins in the soil, that you do bring in people who have that wisdom of the historical trauma, as well as a broad representation of the community to help really be able to name what are those toxins impacting the well-being of our community.
And Sean, can I jump in really quickly on that? I'll talk about the convening that we're doing. Particularly here in the Kansas City region, we have one of our major funders. They sent out a survey to various organizations asking, where they felt they were in the trauma-informed journey. And I think about 80%, either 80 or 85% came back and said they are a trauma-informed organization. And for those who were on the last call, there's definitely a difference between trauma-aware and trauma-informed. And typically, when we talk about the trauma-informed journey, that's a 3 to 5 year journey, and it takes real commitment. And not to undermine anything that was put out by the surveys, but the funder said, hey, we're pretty sure that 85% of our organizations aren't at the trauma-informed stage. So they reached out to Alive and Well Communities and said, hey, can you convene different partners to really bring together our 6 different counties within the Kansas and Missouri side? And we had a common language, common understanding, moving from adverse childhood experiences to adverse community environments. That was a conference that we had on May 10th. And so from there, we're going to be doing some reconvening with those 6 different counties and geographies and continuing this conversation of what it means to have a common language and common understanding of being going from adverse childhood experiences to adverse community environments. And just to answer your question, we actually have started to develop a particular assessment for that. We haven't finalized it, but now that we know there's some interest outside of our area, Sean, just throwing it out there, maybe that's something that we could make more broadly available once we're done with that. So just throwing that out there. Now that we know that there's interest, we'll possibly look at actually making that, we'll look at making that more available to anyone who's interested outside of Alive and Well community areas.
All right, thanks so much for that. One of our other participants is wanting to know a little bit more about how you all changed access to transportation, as you talked about in the example you used.
Absolutely. Sorry about that. So one of the things we did is we worked with a focus group initially, and then we brought in more community voice to that. And then what we did is we partnered with a local managed care organization to run a pilot and start to troubleshoot the pilot. And what we actually saw is that throughout the pilot is word of mouth spread really quickly, and we even saw higher utilization of transportation services. With that, then once we had the data from the pilot of looking at show rates, looking at utilization of medical services, we were then able to take that then to the state and work with the state to craft a transportation policy. And so it was by working locally with one managed care organization, showing then the data and the results of the data, the true outcomes, and then being able to take that to our policy and decision makers to really work to address that toxin in the soil. And if you'd like even more information, please send me an email, and I'm happy to talk to you more in depth about that as well.
Great. Unfortunately, we're at our hour, and that is all the time we have. I will put, though, up our presenters' contact information again so that people can reach out to them. As a reminder, This session has been recorded and will be posted on the Root Cause Coalition website under the webinars page. That's rootcausecoalition.org. It should be up later this week. Thank you so much to our wonderful presenters for their time and expertise, and we look forward to seeing you on the next webinar, which Sean is going to talk a little bit about now.
So we're so excited that today's webinar is part of a larger series. As we continue this discussion of trauma-informed care, we're going to look at specifically operationalizing trauma-informed practices within a healthcare setting. So we'll bring one of our steering committee members and the leader of our Health Leaders Work Group, Dr. Carolyn Day, who's the medical director of a federally qualified health center here in St. Louis, to talk about how we operationalize trauma-informed care in a clinical setting to support patients and to build a live and well community.
Thank you so much to all our attendees and presenters. We will see you again soon.